Okay, so I will sort of go a little bit quickly through the first couple of slides, and then it won't overdo my time. So to get started, I'm going to talk about radiation dose, image quality and utilization, practical tips, and clinical practice improvement strategies for neuroimaging. The reason I was asked to give this talk is that my background is in nuclear engineering from MIT, where I really enjoyed learning about the physics and of radiation and medical imaging, and then went on to become a radiologist and trained for 3 years at UCSF in neurointerventional radiology and diagnostic neuroradiology, and I'm now at Montefiore, as I said, in the middle of the Bronx. So let's get started. Next slide. Okay, so no disclosures, conflicts of interest. And a special thanks to two UCSF faculty, Dr. Cynthia Chin and Dr. Stephen Hetz. Dr. Cynthia Chin gave me a lot of slides for this talk, and I think has given it in the past. And Dr. Stephen Hetz, I still collaborate with in his lab and is one of the best mentors. So just to get started, to quickly show, CT volume is increasing. Thankfully, it's decreasing in kids, and we'll go into that. But for adults, still increasing. It's in the blue, and it is the backbone of the initial imaging test that most physicians think to get: image or CT of the head, and then CT of the spine. People have back pain, and these are very common problems. Next slide. And so still increasing, a little less done than MRI, but also done a little bit more in pediatrics. Next slide. And so I was on the slide for a bit before, but just wanted to point out that the 84% of the pediatric effective dose that comes from all medical procedures and image-guided procedures and diagnostic tests come from CT. Of that 84% from CT, the majority are, and you can click, ahead, come from CT of the head and CT of the spine. The vast majority, as you can see, is going to be a neuroimaging, followed by abdominal imaging, which is only a quarter. So neuroimaging is a huge part of decreasing dose, which is the point of the Image Gently campaign in pediatrics, so that we are using the least amount of radiation possible in this very sensitive patient population. And you can go forward to the next slide. You have to click twice. So in preparing this talk, I was thinking about, what do we have to sacrifice quality for safety? Is that really the question that we're asking? And I would argue that that's not the right question to ask. And if you just click ahead in the slide, the right question to ask is, what is the lowest radiation dose we can use to make the diagnosis or to see the instrument, such as the needle wire catheter during a procedure? And so it's not about sacrificing quality, it's having the same quality of diagnosis and the same quality of procedure, but in the safest way possible. Next slide. And so at every step of the process, before we even think about getting the patient close to a scanner, we can start decreasing the radiation dose from protocoling. And then as the patient gets closer to the scanner and positioning, during the scan is only one part of it really, with the scan parameters. And then even after the scan is over, all of these steps can help decrease dose. And we'll go into each one. Next slide. And this is just an overview of some of the typical doses, with the lowest dose being non-contrast head CT at the head or the neck, which is close to 1 millisievert. And the highest dose in neuroimaging is going to be of the spine, although now stroke, and we'll get into that later in the talk. Next slide. So let's start with protocol. Next slide. So this is the very first step. When a CT is ordered, we need to stop and say, do we really need a CT? Is this really the best thing to do for this patient? And if it is, then we need to implement specific protocols that might be based on dose, such that the patient is getting the least amount of radiation. And the people that are going to be responsible for this are the radiologists. I think at most institutions do the protocoling. However, some it's an NP or a PA. And then the technologist, because the technologist is the one that receives that protocol. And so they're sort of the last stopgap before thinking, is this the correct protocol? Is there another way we can do this? And so every person on the team is involved in this step. Next slide. So in terms of do we need a CT, thankfully there are clinical pathways to help physicians determine whether or not they need to get a CT. So really focusing in pediatrics, there is this head injury decision rule that came out in 2009, and they have these decision pathways for, just a trauma. If you have kids, if they fall at the playground, if they're under 2, there's one, if they're over 2, there's another, and you can go through this based on how they are clinically. It basically allows emergency room physicians or pediatricians to not order a CT, to say this kid is acting well enough that a CT is probably going to be negative. And we have data now that we know that it's most likely going to be negative, overwhelmingly so statistically. And so the risk of the radiation is probably higher than the risk of not doing the CT. And so this has been really helpful in preventing some unnecessary irradiation of children. Next slide. And then again, do we really need a CT? Is there any way that we can do an MRI? MRI doesn't have ionizing radiation. And in a lot of ways, we can just do non-contrast MRI and get the same answer. But even now, they're coming out with specific MRI sequences that are competing with CT. For example, there is on the slide, there is a left-hand column that is the CT, and the right-hand column is this sequence of MRI, the ZTE MRI, and that uses ultra-fast flip angles to basically bring out certain tissues that are going to not typically have a lot of signal on MRI. And that allows us to sort of make it look like a bone CT, if you will. And so this study showed that we can actually measure the degree of neuroforaminal stenosis, and it wasn't different between CT and MRI. So this is one example of a way we don't need CT anymore. And then when we do need CT, there are some situations in which we don't need to have a high dose at all because the tissue contrast intrinsically is very high. So we don't need a high dose of radiation to bring out that contrast in tissue. And specific examples of these protocols that should be low dose are for craniosynostosis. So it's typically of babies and very young children to look at the sutures in the skull. Pre-op sinus surgery, there's mostly air-filled bone and sinuses. So that air next to the bone is a very high contrast. Orbits for foreign body, really, we're looking for metal. So we don't need a lot of radiation to have that attenuated. And then hydrocephalus follow-up where some, especially young kids, are getting multiple serial CT examinations. We really want to use a low dose. And then to avoid multi-phase protocols, in a lot of situations, you don't need a CT with and without contrast. You can just answer the question, the clinical question, by just getting a with contrast, for example. So we don't need to rescan multiple times. Next slide. And so here's an example of a sinus CT where on the left we have a regular dose sinus CT, and this radiation from this was 0.11 millisieverts, and they cut that in half, and you still were able to diagnose sinusitis because of that high contrast between bone and air, as you can see in the middle, where the sinuses are. In the middle picture is half of the dose, 0.045, and even less than that on the right-hand side image, 0.033 millisieverts. And you can see that there's sinusitis here where that air-filled space is opacified. And that's really all we can tell with CT anyway. So we really don't need a lot of dose in certain situations. Next slide. And so then If we are going on to CT and that is the most appropriate thing and we have the correct protocol in place, then we can go into ways to reduce dose based on setting the patient up in the CT scanner. So positioning, next slide. And some of these include angling the head appropriately within the gantry, centering the head or spine or patient within the gantry, removing external hardware and devices, which we'll go into, but will increase dose, giving the patient breathing instructions to minimize respiratory motion, and getting really good IV access so that we don't have contrast extravasation and we end up having to scan multiple times because we scan once and there's no contrast on board, and then we have to, you know, reposition the IV and scan again. I mean, obviously that's basically double radiation dose when if we had a, you know, spent the time to do a good IV in the first place, that wouldn't happen. And then to make sure that the scout is really good, because the radiation dose from a CT scan really is dependent on that scout. And so then people in the team who are really responsible for this step are the CT technologists, in a radiology, or 4 nurses that come down, and an anesthesia team if the patient's intubated. Next slide. So for example, in the head, one of the most radiosensitive organs are the eyes and the lens specifically, because they don't require that much radiation for people to see opacities, 0.5 to 2 gray, and cataracts will happen at over 4 gray, and that's basically ensured. But what we can do is decrease that dose to the lens by angulating the gantry such that the beam doesn't go through the orbits. And you can see by the graph on the right of the slide that you can decrease that by nearly 90%, that dose, at an angle of up, 30 degrees or more. And then further decrease in dose will be just moving the beam 2 centimeters superior to the orbit, so that you're just not scanning the eyes at all, and the scatter will be decreased as well. Next slide. Bismuth shielding, I've never seen this used. I don't know if anyone uses this, but it is technically another way to decrease lens dose, and you can put it on a patient after the scout. If you put it on before the scout will automatically, and we'll talk about this, increase dose. So you want to put any shielding on after you take the scout, and then that should shield the orbit, as you can see in the picture of the CT on the right. And there will be some artifacts related to that shielding. And some ways to decrease that would be to put an air gap or some sort of step off, maybe some gauze in between. And then they can be expensive, so you can reuse them if you wrap them in plastic. But again, I don't know how widely used these are. There's really controversial thoughts about any shielding whatsoever with CT in terms of increasing scatter and ultimately increasing dose. So I don't know if anyone uses this, but I think that remains to be seen. Next slide. And then centering the head within the gantry in terms of the isocenter. And so you really want the head in the middle of the head at the isocenter, and you're going to have the highest signal, the least amount of noise, and therefore the least dose. And so as in this graph shows in one study, that as the patient was moved more superiorly on the table, the dose actually increased to the brain because of the tube current basically read it as needing more dose, and then the bow tie filter on the system. Next slide. And so then while we're scanning, we can also do things to decrease dose. Next slide. We can collimate, we can decrease time, we can have decrease the tube current and have automated tube currents. And the people that are responsible for this are going to include the CT technologist in setting those parameters, physicists, radiologists to some extent. Next slide. And so we want to lower the beam collimation because we want to decrease the dose contribution that comes from scatter. So all of those sort of lower energy photons that are not providing signal, they're not providing increased contrast, they're really just adding dose. They're really not adding anything. So they're not valuable photons. We want to get rid of those. Next slide. Faster gantry rotation, we want to decrease motion artifact. Next slide. Lower KV, and this does depend on the MA, but if you lower the KV, you increase the photoelectric effect, increase tissue contrast, and so that can decrease dose. Next slide. And then ultimately decreasing MA, and I think the most papers that are showing the decreased dose from CT really focus on this, because I think this is the single easiest way to decrease dose. The MA is proportional to tissue contrast, but as I'll show you with some of these studies, you're not decreasing tissue contrast such that we can't make the diagnosis. And as long as we can make the diagnosis, that's what the patient needs. That's the best thing for the patient without unnecessarily irradiating them. Also, image noise is proportional to the square root of MA. So if we decrease MA by 50%, you're not going to decrease the image noise as much. So at what is the lowest MA, which we can make the diagnosis through this acceptable tissue contrast and through acceptable noise? And that's really the question, because that's the safest thing for the patient. And in this study to the right of the screen, you can see that the MA on the right-hand side was decreased by half, and we can still see the tissue contrast. There are 3 slices, the top through the posterior fossa, the middle through the thalamus and the basal ganglia, and the bottom through the centrum semial valley, and we can still see the parenchyma, the gray white differentiation, the sulci. We can make the diagnoses that we are able to make by CT at half the MA, which is half the dose. Next slide. And this is a geometrically magnified view from the same study where it is half the dose. And admittedly, you can see there is less of a gray-white differentiation. However, I can still see gray-white differentiation. I can see that there's no sulcal effacement. I see that there's no stroke. There's no blood in the sulci. I can say there are none of these things that are the things we're trying to see by CT. We can't say there's no small, tiny mass here, but we wouldn't be able to say that at 170 MA either. And you need an MRI for certain things. So for what we use CT for clinically, you don't need as much dose to be able to confidently make the diagnosis as a radiologist. Next slide. And so one way we can decrease MA is to use adaptive tube current modulation, and this can be done in the angular and Z dimensions, or the X, Y, and Z dimensions. And what this essentially does is when you take the SCOUT, the CT scanner will automatically modulate the tube current, or MA, such that you get lower MA where you don't need it as much. For example, in the level of the shoulders, you can see that it's very high because you need to get through all of that tissue, all of that bone. You need more MA. You need more photons. And so then through the lungs, because you have that contrast, intrinsic contrast of the tissue with air in the lungs, you don't need it as much, and so it goes down. And so the same thing when you do a SCOUT, I couldn't find a really great picture of it like this one, but if you go through the head and neck, that's really helpful because you need more photons as you go through the shoulders, but you don't need as many as you go through the thin part of the neck where our thyroid is, and our thyroid is particularly radiosensitive as well. And we are doing a lot more head and neck imaging because anyone who comes into the CT now with symptoms of stroke is getting a full head and neck CT, CTA, everything. So we really want to pay attention to how we can decrease dose in this in these patients. Next slide. And lastly, post-processing. Next slide. So we can use software to give us better signal, increase spatial resolution, and decrease noise. And so what does that mean? That means we can decrease dose, because if we can do all of these things with software, then we don't need as many photons to do it for us. So we need to use the tools we have now which we didn't always have, especially at the advent of CT in the 70s. And so that will help us decrease dose. And the people that are really helpful with that are the technologists, the radiologists, the physicists, PhDs. I'm sure there are a ton of people, depending on the institution, who can do post-processing, but there's way more than we can go into in this discussion on the different techniques that people are using now. And it's wild how much is out there and how much we can do with a little amount of radiation. Next slide. And so generally speaking, iterative reconstruction algorithms are now the best way to do this. And this incorporates both on statistics and system optics to do repetitive iterations to show at the detector, to improve at the detector how many photons were truly there, and improve signal, and improve spatial resolution. And this is in comparison to filtered back projection, which was the initial way that we got the signal out of CT scanners, and has, I think, mostly been replaced, but you get less artifact with these iterative reconstructions as opposed to the convoluted math that the filtered back projection required. You can get up to a 31% decrease in dose, and there are a ton of these types of systems, and they're all sort of industry connected now. So GE has their adaptive statistical iterative reconstruction, and there are different names depending on the different vendors. Next slide. And so this is a study that's just showing us on the top, the standard CT, and then on the bottom, after iterative reconstruction. And you can see that, you can decrease the dose, you can reconstruct, and you're not losing any of the signal or ability to make the diagnosis. Next slide. And so now I'm going to move on to some procedures and thoughts of decreasing dose during procedures. And so two areas I'm going to talk about are CT guided spine procedures and stroke. And I happen to do both and love both, so I'm excited to talk about this. But the CT guided spine procedures that we do, I think, are only increasing. And it's as many things as a simple lumbar puncture to myelogram when a patient can't get MRI, if they have a pacemaker or a spinal cord stimulator. If a patient is having pain, there's a lot of procedures we do for pain, such as facet blocks, nerve ablations. And a lot of data is coming out that are increasing where and what we can ablate to decrease pain. And one of the more recent is the basivertebral nerve within the vertebral body. And then vertebral augmentation, which is where we put cement into the vertebral body. And then, of course, biopsies. Biopsies are very, very common because, unfortunately, metastatic cancers love the spine, or infection. So we do a lot of spine biopsies as well. Next slide. And so there are three main ways that we can decrease dose during these procedures. We limit scanning to the anatomic area. So we find out exactly at what level we want to target, and we only have to scan that level. We don't have to scan the entire spine. It's unnecessary. We take a scout of a very small area. We take very few slices. When we line up our needle to go from the skin into where the target is, it really should span only 1 to 2 slices. So it's really not a lot of radiation. And the MA we can set, and we set it as low as we can go. Again, this is taking advantage of not the intrinsic tissue contrast, but the intrinsic contrast between tissue and the needle. And because metal is such a high attenuation coefficient, it's easy to have that contrast and use a very low MA to still see our entire needle, especially when as it's going into the spine through just muscle and soft tissue. And then axial scanning versus helical scanning. And we, can just, as I said, do very few slices, step and shoot. It's all very low dose. Next slide. So this is, and just click one more time. This is a dose report courtesy of Dr. Chen. If you just click, one thing should pop up on this slide. And she had done, and we, I did all the time at UCSF, multi-level facet blocks where we take our needle and it's coming in this picture from the back and it's going into the facet joint in the lumbar spine. And you can see that this dose length product is 106. And so this is very low. The millisieverts this corresponds to is far less than a diagnostic lumbar spine CT. And so this is many, many levels, but very few images and radiation is needed to be able to do the procedure safely and effectively. Next slide. And so this is in distinction, and we'll move on from spine to stroke to the radiation dose and stroke imaging. And so now with the, since 2015, when 5 major trials came out that allowed neurointerventionalists to remove clots from brains and significantly improve patient outcomes and save lives, this has sort of taken off. And so now anytime a patient comes into the ER and has stroke symptoms, over 18, I should say, they are probably going to get a non-contrast head CT and a CTA at minimum. Many places do much more than that. And that includes a non-contrast head CT followed by a multi-phase CTA. So a CTA in the arterial phase and 1 to 2 delayed images. Then CTP, which is CT perfusion. And that's the very high dose step of stroke imaging. And so you could see the dose length product here is many, many times that of a spine procedure. And so this is probably now becoming one of the highest areas of dose in neuroimaging. Next slide. And so I wanted to show an example of this. So you have a patient that on the top, there's a non-contrast head CT and a CTA, and then on the bottom are the perfusion images where the imaging is long. It can go on for 48 seconds. It's basically a cine mode of successive gantry rotations during the administration of contrast. And it really wants to monitor that first passive contrast through the arterial, parenchymal, venous phases so that we can get an idea if there's an area of brain that is not perfusing or at risk and can indicate that there is tissue that is non-viable, at risk of viability, and still viable. And so that has been previously used to be helpful in making determinations of which patients should go on to, next slide, thrombectomy. And so this slide on the left is the summary output that radiologists and neurointerventionalists and neurologists and everyone sees in the hospital, where it shows on the left-hand side, the thumbnails, that there's no infarcted tissue or no non-viable tissue. And then on the right-hand side, the green indicates that that's the tissue at risk because of the angiogram, which is shown on the right, where there is a vessel occluded. And so if we open that vessel, you can save all of that green area at risk, which includes on the left side our motor function and ability to live a functional life. And so I think at this point, everyone would want this intervention done, but it does require a lot of radiation dose to get these pictures and to do the perfusion. And so I think we need to be cognizant of that. And I think there are a lot of studies going on about how to decrease that dose, which again, I saw a lot of decreasing MA to do that. So next slide. And so this is just a summary outline of CT perfusion and the mean dose length product, which is the highest part of this. And that's double any other part. So it's double the head CT, it's double the CTA, it's double the delayed phases of CT. And so the CT perfusion is really, I think, what we need to call into question about whether or not we still need to do that. And then next slide. As As I mentioned, there are studies that have looked at decreasing MA to be able and done the perfusion to see if we can, and this is modeled, to see if we can still get the information at half of the MA that we can, and it is definitely possible. So that's another way to decrease dose for CT perfusion. Next slide. And then another way that we can do it is through decreased temporal sampling, because as I mentioned, this CT perfusion is a long scan. It can take up to 48 seconds. It's usually about 40 or 50 mils of iodinated contrast, and then you can scan at whatever set interval. And so this, from this study, shows that if you decrease scanning time from 1.5 to 3 seconds, it's still, you're going to get half the number of scans, but it still shows pretty much the same information. It does start to diminish as you go to 6-second intervals. But I think that, you know, I think in the era of data that's coming out from the interventional side, CT perfusion may not be as necessary because it looks like whether or not there's tissue at risk or whether there's tissue that's already infarcted, patients are still having benefit from opening the blood vessel. So in that case, we may not need to do CT perfusion as much, but there are other reasons people do CT perfusion, such as in patients who have vasospasm or other reasons for having some stenoses. And so I think we should just be cognizant of this technique, which I think will still be in use, and ways in which we can decrease the dose, which I think is mostly by decreasing MA and decreasing this temporal sampling. Next slide. So in summary, it would be helpful to have standardization to ensure everyone's getting the lowest dose from CT. It would be unfortunate for one person to go to one emergency room and get a full dose CT that they didn't really need and go to a different emergency room and get half the dose. So I do think that that is something that we should work for going forward. No dose is the lowest dose, so not doing CT is the lowest dose you're going to get and should be considered, especially in being cognizant of pediatric imaging and the necessity of irradiating kids. But if CT is needed, which is very helpful, I love CT, I read CTs every day, the dose can be decreased at every step, and you can still do what you need to do clinically and not irradiate the patient as much as, you know, maybe we previously have, and a lot of work has been done to show this. And that's with diagnostic radiology as well as CT guided procedures, in which we typically do them in the spine and neuro. And then stroke imaging dose remains high, particularly the perfusion. But again, I think that there are ways we can, at our institutions, decrease the dose from stroke imaging and, you know, really help patients with stroke intervention. Is really helping patients. So this is definitely a study we still need to do. I know I ran through all of that pretty quickly, and so sorry for the technical issues before. Next slide. But please don't hesitate to reach out if there are any questions, you know, follow-up questions or anything. I would be happy to talk about any of these topics more in depth.
Thank you so much, Dr. Baker. Thank you for being so flexible, jumping around to different connections and phone connections. Here's what we're going to do. You can, we're going to take a break at 3:10 for 5 minutes. So there's 2 questions in the Q&A. You wrapped up pretty quick, so feel free to take the next 5 minutes to answer those questions. Then we'll take a 5-minute break, and Rebecca will get started at 3:15. And are you able to access, I'm sorry, are you able to access the Q&A, or
I'm
would it be
looking now.
I can read them to you if that would make it easier.
Okay. Oh, here
You
it
let
is.
me know.
I found it. Okay.
Okay.
Oh, I found it. Okay. A little concerned about those super low effective dose estimation and comparison, such as 0.11 millisieverts versus 0.035 millisieverts. Not sure those values were even built to have that much of accuracy, just a comment. I mean, I agree. I think that, I think it's interesting, and there's definitely a fear actually of having not enough radiation, and a fear of missing something if we don't have enough. And it's not radiation, I should say, it's signal. I mean, people really just want enough photons so that we can see what we need to see. And I think that when it comes to certain areas, it's particularly in the sinuses, I think it's interesting to look at these papers to see how low can we go and what can we still see, in the sense that it helps people accept that we don't need to have all of the resolution to answer that specific clinical question. And that's definitely where I'm coming from, is can I answer this clinical question, or do I need a better scan? And in a lot of cases, particularly when it comes to sinuses and things like craniosynostosis, I don't need to see all of the brain parenchyma. That's not why I'm doing the test. That's not what the why it was ordered. That's not the clinical question they're trying to answer. And if there is a parenchymal, brain parenchymal question, they should get an MRI anyway. So I think that's why it's interesting to highlight that, you know, maybe we can go to lower doses. And if we do decide, you know, as a community, what dose is acceptable, we should probably do it everywhere. But especially with kids, you know, there's data to suggest that even one CT can be harmful. I didn't show that data because I think it's a little controversial, but I do think it's interesting to look at these papers and really ask ourselves, how low can we go and be comfortable? And then as a neurorad, does your threshold for image quality change as you read through your shift? For example, is the same diagnostic task easier at the start of your shift versus the end of your shift, all other things being equal? Absolutely. We are humans and tired at the end of a shift, and volumes have gone up. I don't feel those graphs did justice to how neuroradiologists and probably all radiologists feel. The job market is excellent. There are too many scans to be read and not enough radiologists. And so we're reading more than ever before, and each scan is more complex in the sense that there are way more images, and so everyone gets, you know, really exhausted. With that being said, I think that you know, every person deserves the best care. And so when you get really tired, I think people recognize, or I think there's a recognition of it. And so I think people, I actually tend to be a little more slow and careful at the end, because, you know, you don't want that fatigue to cause you to miss something. In terms of image quality, I would say no. It's probably more frustrating if it's worse, because then, you know, you're even more, I guess I'm even more concerned, and this is personally speaking, more concerned that I'm going to miss something. And so I actually want the quality to be better at the end of my shift. And so, you know, I you know, write a lot of caveats in my reports that if something is too motion degraded, or it should be repeated, I don't hesitate to say that either. And so I know that that would indicate getting another scan, but at the same time, my job is to answer the question. And so if a patient can stay still and do it at the lowest possible dose, that's ideal. But I will answer that question, and I'm not afraid to I guess I'm not afraid to increase dose or rescan patients to answer a question, but at the same time, I don't want to be afraid to decrease dose if I can answer the same question. So I really just try to keep that goal in mind and do what's best for the patient. And I think that that's helpful to guide, but I think, you know, there are fears in both directions, decreasing dose too much, and then, you know, scanning people too much. So it's definitely a balance, and you know, I hope then that's part of why I think standardizing things would be really helpful, and it would be helpful for everyone. I think the whole team would benefit.